So the learning objectives of this lecture will be to go through with you if it's only nice to have 3D planning, or is it really useful and convenient? What are the clear benefits from 3D planning? And I would also tell you what I think is the best protocol when you do 3D planning, not to miss anything important. As we all know, orthognathic surgery has the aim to re-establish function, but not only function, also create aesthetics for patients, and we want to get the most stable and reliable outcome in the shortest time possible. With 3D planning, it's actually really possible and nice to achieve a precise outcome and a predictable outcome. It's easy to determine 3D asymmetry and proportions of the face. We can decide on movements of not only the teeth and the jaws, but also actually the condyles, which I find that is very interesting, especially in patients that have condylar pathologies. So we can nicely look into what is happening with the dental arch, what is happening in the spinal area, and with the chin, and also the condyles. So compared to the traditional planning with rigid condyles in the articulator, we really now have new possibilities to decide the condylar movement during the planning and look into where we might have overlapping parts of the bone, not to end up with flaring or condylar sag. So we can avoid condylar flaring with 3D planning, and we can obtain the planned condylar position and occlusion already preoperatively, and we can also obtain symmetry of the angular area if we use patient-specific implants for the mandible. But to obtain all of this, you have to find the stable pain-free joint position before surgery. When I do surgery, I always do the maxilla first, and I don't use maxillomandibular fixation for placing the maxilla because the patient-specific implants are so reliable. For the lower jaw, I still use the final wafer or splint, and if I have a very big advancement, I would use this cage-like structure on the implants for the lower jaw to obtain a nice and straight inferior border of the mandible. So I always start the 3D plan with taking a solid bite index of the patient with the condyles in the pain-free stable joint position. You have to make sure that the patient has pain-free condyles before you start planning surgery. Otherwise, it might be that you will end up with condylar resorption and relapse of the occlusion. I use this solid bite index when I start my surgery. So when the patient is under general anesthesia, totally relaxed, I try in this condylar index. And if it's reliable and it's exactly the same position of the condyles that I already have obtained from the outpatient clinic, then I know that plates for both the maxilla and mandible will be reliable and they will fit very well. If I see that there's a small discrepancy, then I know that I can still reliably place my maxilla into the right position, but I might have to do some adjustments with the plates and screws for the lower jaw. So this is what I always start with. And then I like to decide the occlusion and have the haptic sensation with models. And then we scan this into the 3D plan. But of course, you can also decide the occlusion virtually online.